Assalamu alaikum dear doctors. In this video I am discussing about respiratory distress syndrome RDS, and this information I have taken from RCPCH Theory and Science book, case number 36. So, respiratory distress syndrome or RDS occurs mostly in premature infants and its incidence is inversely proportional to gestational age. Remember, inversely proportional to gestational age and birth weight 1 to 3. It occurs in 60 to 80% of infants less than 28 weeks and 15 to 30% of those between 32 and 36 weeks of gestation. So, 60 to 80% occur less than 28 weeks and 15 to 30% occur 32 and 36 weeks of gestation. It is caused primarily by deficiency of pulmonary surfactant in an immature lung. So, due to deficiency of surfactant, respiratory distress syndrome is developed. It can also result from a genetic problem with the production of surfactant associated with proteins. Respiratory distress syndrome is a major cause of morbidity and mortality in preterm infants 4 to 6. Signs of respiratory distress syndrome are usually within minutes after birth, although they may not be recognized for several hours in larger babies. It results because of an insufficiency of pulmonary surfactant which leads to airway collapse. It is inefficient for airways and lungs to completely collapse during expiration, as reinfection requires much more energy than widening of a partially closed open airway. Under normal circumstances, airway closure is opposed by maintenance of functional residual capacity. Functional residual capacity at a level of above the point at which always collapse. The critical closing volume CCB is increased in surfactant deficiency, bronchiolitis and pneumonia. FRC is reduced when lying supine, during anesthesia and during sleep. So, we learned that CCB, that is critical closing volume, that deficiency, that increase in surfactant deficiency, bronchiolitis and pneumonia, and FRC, functional residual capacity, that reduces in lying supine, during anesthesia and during sleep. Three factors predominantly influence the functional residual capacity. These are elastic recoil of the chest, the time allowed for expiration and the expiratory flow rate. Children will usually attempt to maintain FRC at a level above CCB by several synergistic mechanisms. The newborn child has a limited number of ways to oppose airway closure. Whilst elastic recoil of the chest cannot be varied, it does increase with age, and hence older children are less susceptible to complete airway closure. Increase in respiratory rate leading to a shorter expiratory time and grunting both lead to an increase in FRC. Grunting requires considerable effort itself and it is usually a sign of significant illness. Grunting frequently occurs in combination with nasal flaring and intercostal or subcostal retractions as well. Three are associated with increased work of breathing. The distinctive sound of grunting is produced when the glottis is closed during expiration. Remember this line. The distinctive sound of grunting is produced when the glottis is closed during expiration. This increases end expiratory pressure in the lung, similar to increasing the PEEP setting on a ventilator, and helps to improve oxygenation in children with ventilation perfusion mismatching due to regional airway closure. As the disease progresses, the baby may develop ventilatory failure and prolonged apnea. In most cases, the symptoms and signs reach a peak with 1 to 3 days, after which improvement is gradual. Improvement is often heralded by spontaneous diuretics. So, we get some information about respiratory distress syndrome, that is, it mainly occur in preterm babies due to surfactant deficiency, and 60 to 80% occur in less than 28 weeks of gestation, and 15 to 30% occur 32 and 36 weeks of gestation. Some genetic cause also present for respiratory distress syndrome. A surfactant which leads to airway collapse. Another important point is that tell that grunting is produced when the glottis is closed during expiration. Please do subscribe and share Dr. Emma's Medicine YouTube channel. Thank you.